Hello. Um, for those of you who are trying to join me and Dr. Davis on Instagram, we are now going to try and do it on Facebook because apparently you need 1,000 followers to do a live on Instagram now. So let me see if Dr. Davis can request to join. You know, it's always something. It's always something. And I realize that I've done a fairly poor job of explaining these videos. So while I'm trying to figure out how to add Dr. Davis, I will tell you my story. Oh, okay. Approve. Yeah. Fantastic. Made it go faster than I thought. We're adding. Okay, but my name is Catherine. In 2019, I joined a clinical study at the NIH, and in 2020, Dr. Davis removed my stomach. So hello.
Oh
Well,
my goodness.
our dedication to the people is
I tell you.
I didn't know that it was going to happen. I really didn't. I thought, well, this is it. We've we've maxed out. I don't have 1,000 followers, and now
Well,
I'm
first of all, I'm just now disappointed.
I know. I'm disappointed in myself. I'm also a little bit humbled. So,
I think you were at 971, so we just need
look,
29 more people.
yeah, come on, guys. Make Instagram Live possible.
Yeah.
How are you?
Oh, well, now I'm okay. The last 50 or the last 15 minutes were exciting.
Yeah, I
Um,
know. That was fun.
yeah, yeah. No, I'm great. How are things down in Texas?
Still hot. It's still hot here,
Really?
and I keep waiting for fall to come around, and it's just like, nah. I'm good. I'm gonna hang out.
Yeah.
But yeah, so I'm just still just not even close to wearing a sweater. I'm jealous of your pullover because I'm
Well,
shorts.
I had to wear it today. I think this morning when I woke up or went outside, it was around 55. It was kind of rainy and dreary and kind of fall like, you know.
It was 90 here yesterday, so yeah,
Whoa,
yeah.
really?
It's still very
That's
hot.
kind of crazy.
Yeah.
That's kind of crazy. However, it's so funny. This is random, but I was talking to somebody the other day who's getting ready to go to the Southern Hemisphere,
Okay.
and I said, he grew up down in Argentina, and I said, what's it like having Christmas in the Southern Hemisphere when Christmas occurs in the summer? And he goes, well, we just take some flour and sprinkle it on the Christmas tree to make it look like snow, even though it's like 90 degrees outside. And I thought, God, it's got to be so weird.
Gonna be so weird. Yeah.
Yeah.
But I mean, here, sometimes Thanksgiving we're in shorts and other times it's like iced over. So you really don't know what you're gonna get, but it makes it fun.
Oh, really? Yeah.
Yeah.
I remember doing that in Florida. But anyway, I don't want to take up any more time because I think we have a packed agenda.
We do. We do. We have a lot of things to talk about. First, I have to show you my seahorse pillow.
Oh, no way.
I
That's
know,
so
isn't that cute?
awesome.
I thought you would enjoy that. Pottery
Yeah.
Barn. Yeah, yeah. So for
Pottery
the
Barn.
900 people who follow me, I can be an influencer and be like, go buy you a pillow at
Listen,
Pottery Barn.
Pottery Barn doesn't know what they're missing.
That's right. That's right. Okay, so let's talk about you've been in University of Maryland for almost a year now. It's
Yeah.
wild. And
Yeah.
how's research going? How's
Yeah.
it all settling in?
I think I can't remember the last time we spoke, but yeah, I'm about 10 months in now, and I think things are starting to get more settled. So for instance, I was just over in the lab this morning and we're kind of stocking the lab like, with the supplies and stuff we need. I think I still am waiting on one more shipment of um, frozen tissue and material and stuff from the NIH that is still, due to be shipped from there over here. So we're settled there. Um, we've got I just submitted a grant to develop a kind of a diffuse type gastric cancer or CDH1 related diffuse gastric cancer research program here. The proposal was designed to really give us an influx of money and funds to do that. So it's a lot of good things going on, but it's taken a little time. I'm kind of impatient, but 10 months, it is what it is.
Are you doing surgeries? Are you doing gastrectomies?
Yeah, in fact, tomorrow, actually, I just saw a lady in the clinic this morning with gastric cancer. I was supposed to do a gastrectomy tomorrow on a patient with gastric cancer. It got rescheduled for some reason. But yeah, I'm seeing folks. We're doing all the stuff. It's just, I think I need to do a better job of getting the word out, I guess, that I'm still alive and I'm here, but yeah, it's going okay.
Okay. Well, and so is email the best way to get in touch with you for people who want to do a life check and
Yeah.
a wellness
Is he,
check?
is he alive?
Is he alive? Yes.
Um, so I think email for most people is probably the most reasonable thing. I mean, you can email me anytime. I'm pretty responsive to emails. People could call the office, but then it's like you got to leave a message and then I got to, whatever. But email's a great way to get in touch with me. I would say social media, but, I downloaded the Facebook app just for this. So, not so sure Facebook's going to be the way to go.
Right. It may be our way to go forward, with
Yeah.
okay, so last video, you mentioned something, and Emily Rumble asked if we could clarify it. So I just want to give you
Okay.
an opportunity to do that.
Yeah.
So you said that surveillance is reasonable for some people, at least in the short term. Do you want to add some color to that?
Yeah, what I'm trying to do is be a little bit more cautious with my recommendations. And this comes a little bit from some of the research that we've published, where, when we go through the publishing process or the research, process, and we submit, let's say, a manuscript, there are other people out there, our peers, who review that manuscript and provide us input. And they're doing it from kind of a scientific, standpoint to try to make sure that we're not overstepping our bounds, right? It's like you imagine the days of snake oil salesmen and this magic tonic will regrow your hair and blah blah blah, right? And I'm out of money. So so one of the things that people said, and I think it was a valid criticism, is they said, you're publishing these data, and the truth is we don't have 20, 30-year follow-up, right? We don't have extensive, long-term data. So
Right.
every time we've published, people have said, you only have, an average follow-up in these patients of, 4 years or 5 years or whatever. And so with that criticism, I'm just trying to say to people that, based on our current knowledge,
Mhm.
surveillance is reasonable in patients, at least in this period of time that we've been following people. And so when I say in the short term, I mean, let's say an average of 5 years. Now, there are people out there that have been under surveillance for 10 years, and in some places even more than 10 years. The problem is you can't kind of use those examples, anecdotally. You got to take the whole, bunch of data. So we're getting ready to publish some more follow-up, right? And in that follow-up study, there are some people that have been under surveillance for 10 years, but the average follow-up for most of those people is still only around 5-6 years. Mm-hmm. And so we're going to have to say in that paper, right, surveillance seems to be safe, with an average follow-up of 6 years, right? And that keeps us, in this kind of safe space where we're not trying to sell people and go, oh yeah, you could be under surveillance for 20 years, because we technically don't know that.
Right. Okay.
If
hopefully
that makes
that,
sense. Emily,
that
Emily, I hope that helps.
I think that it is such a personal decision, and it's also such a unique decision because
Yeah.
every single person's family history is going to be different. Every
Yep.
person's personality, whether they can tolerate the surveillance process, um, it's so different. So it's
Yeah.
hard for us as patients to look to doctors and be like, can you help me make this decision when you
Yeah.
really when there's nothing that's saying like, no, you need to have it now. It's a hard position for y'all to be like, nope, you should do it because I mean, y'all go home and it doesn't, it of course it affects y'all, but it's not changing the patient's life like it is.
Yeah, and I think, listen, on the part of the physician, I think, most physicians I know really don't want to give people bad advice, right? And
Yeah,
none of us wants to be wrong, right? None of us wants to say, "Oh, you'll be fine," and
yeah,
then, let's say 6 months later you're not fine, right? I think
right.
that would bother, I hope, most doctors. So I think that's kind of the challenge, right? Is I think I know what, could be good for most people, but I'm not like 100% positive. And I think, it's reasonable to have a little bit of that, uh, reality check and go, yeah, I may be wrong.
I mean, that was our first conversation. I specifically remember asking you, like, don't sugarcoat it for me. Like, I want to hear,
Mm.
like, the worst outcome possible.
Uh,
And, but I went into our conversation knowing I was going to have the surgery because
yeah,
I couldn't, I mean, I'm just an anxious Annie. So
yeah.
I was like,
Did
get it
I?
out of me. Get
I'm
it out
I'm
now.
curious. I'm curious your recollection. Did I sugarcoat anything?
No, you did not, sir. No, you did not. You told me, and I quote,
Uh-oh.
because uh, this was also let's all keep in mind this was 2019 when we had this
Okay.
conversation. So the percentages that were
Uh,
being floated around, it
mm,
was 90% likelihood, 80 to 90% likelihood of getting hereditary diffuse gastric cancer in your lifetime. And
mm.
for lobular breast cancer, it was like 50% or something like that. So
Yeah,
that's what
yeah.
I walked into it with. And you told me, you kind of leaned back in your chair and you did the, I can't tell you what to do. It's your choice, your body. And and he said, but what we're finding is that it usually progresses in your 30s, and if it does progress, we cannot catch it, we cannot cure it, and you'll die. So but I asked you what the chances of me dying from this were. Um,
Oh,
and before we even had this conversation, I said, I'm gonna have the surgery. So, but
yeah, yeah,
I just want to hear what the worst
yeah.
could be. But I think that that's changed a lot now, right?
Well, by the way, the reason I make all those faces is because I recognize that my conversations with people have evolved over the last, 10 years.
Yeah.
And I even said to somebody the other day, I said, had we met in 2015 and had this conversation, it would have sounded very different. I would have probably said, "Oh my gosh, yeah, let's take your stomach out. I think it's the right thing to do." Blah blah blah. And I think my conversations nowadays are just really dramatically different, and I think for good reason.
Mhm.
But I just talked to somebody the other day where I said kind of something where I said, "We just don't know, and you may never develop cancer. If you do, our hope is that we catch it early. And then obviously, if we don't catch this kind of cancer early, it is pretty deadly. So the conversations are similar, but the nuances, have changed, or there is nuance, I guess.
And at the time, that was the best information we all had,
Yeah,
And
yeah,
I mean, I don't regret it at all. And if my stomach helped lead to evolving conversations, then I'm glad for the next person. But I
yeah.
have zero regrets over. my choice. So, and
Yeah.
we could talk about surveillance and surgery. You know, I mean, it is a conversation that A is so polarizing and B is just so complex. We could spend
Yeah.
1,000
Well,
hours on it.
okay. And so I don't want to, yeah, you're right. I want to be able to move on to the other topics. But with that said, I think I do want to say that, um, oh, crap, I lost my train of thought. That's what happens when you get old. Um, Jesus, I will come back to it. Man, there was something on the tip of my tongue and I lost it. But you said you don't regret it, and hope we learned something. By the way, so many of you guys that came to NIH when I was there, you are the reason why we've learned a lot, right? You are the reason why I was just in St. Louis last week and I gave a talk on kind of why or how those little signet ring cells change or evolve. The only reason we know that and the only reason we can do that kind of research is because of people like you. And so I think this goes back also to being an advocate for or advocating for how you guys taking care of yourselves, but doing it in the context of research, especially for something really uncommon, is super important.
I agree. And for the breast cancer as well, I know that there's so
Yeah.
many more avenues of treatment for breast cancer, but for if if the money that can help lobular breast cancer, if there's any kind of like connection to the stomach, like, you know, I would love to see that. I would love to see I don't know, a breakthrough from any sort of route, whether it's like,
Yeah.
but all of that to say, okay, so
Okay.
for today, I
Yes.
thought that we could focus on you've made the decision to have your stomach, you have your stomach out, you've gotten through those first 8 weeks, which are really horrible, and now you're looking at life without a stomach and
Uh-huh.
maybe some of the aspects of life that change that you don't anticipate, or
Mhm.
things that you have to think about. Um, Selfishly, I would like to talk about bone density
Oh,
because
yeah.
this has been just top of mind for me. So, can you
Yeah.
kind of explain what losing the stomach, how it impacts bone density, kind of what you guys found through all of our DEXA scans at NIH?
Yeah. So excellent topic. And the first thing I'll say is there's a lot we still don't know, right? So I like to start with that. Um, the second thing I do want to mention briefly is the impact again that you guys, meaning patients, family members, whatever, the impact that you guys have. The main reason that we ever started to get DEXA scans and even look at bone density was because a nice lady named Karen Chelkin Schreiber was on the phone with me one day and she said, Jeremy, I want to understand why I have whatever osteopenia and
Mhm.
why my doctor is telling me, whatever. We want to know and we need to know. And she, how Karen was kind of, she pushed pretty hard. And so I said, we're at the NIH. We can do it. Let's just do it. So that's what, so it really started because of Karen. So with that said, there are a couple reasons why bone density might change, or maybe many. And the easiest one for us to point to is calcium absorption,
Mhm.
because calcium is absorbed in the very proximal part of the GI tract, meaning the part of the GI tract that, small bowel that starts right after the stomach.
Mhm.
And this very early part of the small intestine gets bypassed essentially when we reconstruct people after a total gastrectomy. So instead of the food that you eat going through or passing through this area where the calcium can get absorbed or is absorbed most efficiently by the body, now all of a sudden the food's not going that way. All the milk and cheese and all the stuff that's got the calcium in it isn't even going there. It's bypassing and it's dumping into the small intestine downstream of where that stuff is normally absorbed. And so from a very basic level, we're missing the opportunity. Or, our patients, you guys are missing the opportunity to absorb that calcium in the most efficient way, the way the body was designed. So I think at a very basic level, we've rerouted things in a way that impairs calcium absorption. So one of the basic studies we did was to look at people's bone density after gastrectomy. Now the challenge is you can't just look after gastrectomy, right? Because you have to have a baseline. And so what we did is we got DEXA scans on people, which is a way of looking at bone density. We got the DEXA scans in people prior to their gastrectomy. And it turns out, by the way, a lot of people walk in the door already with low bone density. So that's before you even touch their stomach. And so you guys have probably heard about things like you need vitamin D, right? Vitamin D we often get just from sun exposure, but you get it in your diet, all that stuff. So the first thing we learned is some people start off already in a not great spot. And then we learned that people's bone density would drop. Now, the main thing we learned in that study was that people that took their supplements, their calcium supplements and micronutrient, vitamins, supplements, there you go. The people that took those like clockwork had better bone density, or I should say not better bone density. They had their loss of bone density was not as severe as people who said, I'm not really good at taking my supplements. So at a most basic level, that was very obvious. It was like, it's a challenge for you guys to absorb calcium. If you take your supplements, you're going to lose less bone density than if you don't take your supplements. So that's the basic explanation. Now here's the challenge. There are probably lots of other reasons. You guys know, or most people should know, that bone health is dependent on exercise, and I don't mean like going to the gym and or Peloton or whatever, but just like getting up and walking and moving and weight bearing exercises. The other thing we found out in that study briefly was that there may be something related to how the machine, the DEXA scan machine, when it's analyzing your bone density, how the background tissue in the body influences the way the machine reads the bone density. And this is getting into the weeds a little bit, but the question being, when you lose a lot of your lean muscle mass as a result of weight loss after gastrectomy, how that loss of lean muscle influences the way that machine reads the bone density. Now that's a whole nother bag of potato chips. We're not going to get into that, but that came up in our research. Super interesting. I'm not quite sure how to explain it. But the long story short is that there's still a lot to learn, but I think at a most basic level, you got to take those calcium supplements because your body's just not going to be absorbing calcium as efficiently as it used to.
Yes, so again, wow, I'm just like such an influencer. These are the calciums that I take. My problem, and something that I had to work out with Rachel, is these have a lot of vitamin D in them to help them absorb and all that. Well, I was getting too much vitamin D that it was having a negative effect. So I get to take 2 of the Chewies a day, and then I do 1 kind of dose of just calcium citrate, just like the horse pill. And that has finally been like my kind of like perfect match. But I lost a lot of bone density that first year, mostly because I was taking a different calcium and didn't read the serving size right. And it was like I was supposed to be taking 2 at a time, and I was only taking 1. So for a year, I was taking half the amount of calcium I was supposed to. But I just had a DEXA, and I don't know if I'm reading it correctly. I sent you my results to look at.
Yeah, I pulled it up. Yeah.
So from what I like, if I'm please read it more correctly than I am, but has my bone mineral density like improved like a little bit? I've been
Yeah.
working really hard this year with like weights and running and walking with my weighted vest, like all to every time I do it, I'm like, it's for my bones.
So let me look real quick. So we read the bone density in a couple places. One is the spine, one's the hip, um, because
I
those are
know I have
areas.
a weak spine, you know, I
You
know.
have a weak spine. You're not spineless though. That's good. Um, so let's see real quick. So from 2020
Hmm.
to 2023, there's been kind of a slow and steady decline in bone density.
In life,
And
bone density.
yeah, now the challenge is, yeah, and that number is kind of similar. Yeah. So, but it looks like in the most recent one, things were a little bit more stable. They hadn't changed dramatically from 2023 to 2025. What I take from this is back to what I said before. Bone density is made up of lots of factors. I know that you're not sedentary, right? You go out and you do stuff and you're active and all that. But clearly there's other stuff involved, right? Um, and I think if everybody just kind of remembers more broadly, why do we care about bone density, right? Why do we really care about defining osteopenia, which is bone loss, and osteoporosis, which is kind of a more significant bone loss? Why do we even care about that? And the answer is fracture risk, right? The risk of breaking a bone. That's basically what it's about, right? Because what we say is once you're in that osteoporosis category, your risk of bone fracture goes up, right? Whether it's a hip or a spine or whatever. So to a certain extent, we're taking a lot of data that was originally developed in postmenopausal women, right, where all of this kind of, grew out of, and then tried to apply it, and now we're trying to apply it to young, otherwise healthy people who aren't postmenopausal. So I think there are challenges in that, just overall, comparing, what's osteoporosis in a postmenopausal female to what's osteoporosis in maybe a young man. Um, all I can say is that we have to continue to gather data, and people have to do what seems kind of reasonable.
Mhm.
Don't forget at NIH we were getting those DEXA scans yearly because I could.
Hmm.
In the real world, even if you have osteoporosis, you're getting maybe a bone density scan maybe once every 3 years, maybe once every 3 to 5 years, so we have to kind of keep all this in mind because again, it's all about risk and risk stratification. But
And
are you at risk of going out there and breaking your hip?
honestly, don't tempt me, okay?
You might try.
Uh, I well, and the doctor who ordered the DEXA, she was like, we're going to refer you to an endocrinologist. And my
Yeah,
issue with that is I would still like to have a baby one day, and the drugs that they're going to give me to, help bone
yeah,
density, I'm not willing to put that in my body until my childbearing years are over.
yeah,
So it kind of puts you in this like, you know,
yeah,
and
yeah.
eh,
I
so
think listen, I, I don't have any data to say this, but I mean, I think most of you guys, yes, your bone density has probably changed,
right.
but it's kind of like I think you're going to be fine, but just like we just still don't know. And this is the long-term data part. You're young. I don't know what's it going to look like when you're, 60, and what I mean, and from a bone health perspective.
Right, right. Well, if Bariatric Fusion would like to sponsor me, uh, you know, uh, and I think
You got to hashtag those people, whatever you do.
Yes, I'll tag them. So you said something interesting that kind of relates to a different topic, but let's segue there. Um, at NIH, we were so spoiled. We were so spoiled by the concept of walking into a building, having people who were extremely educated about our situation, our specific genetic variants, and we could have any test, any blood draw, any, scan, whatever, and it was just like here, all for the
Yeah.
sake of research. And I
Yeah.
think a lot of us who came through NIH then kind of like got into the real world, and it was like, oh, now I have to explain this to my doctor. I have to explain it
Yeah.
to, um, and I want to hear what you have to say. I just have maybe 2 points from the patient's perspective. The first being, whether you have CDH1 or not, this is a universal issue. Like every person has to kind of battle the healthcare world to have doctors look at them in a holistic manner. I have
Yeah.
friends who there's nothing wrong with them and they're fighting with this doctor, that doctor for a hormonal panel. Well, can you look at it and this result and that
Mm.
result? Like it's completely universal. We're not special just because we're
Yeah.
missing our stomach. Do we have to go to the doctor a little bit more? Yes, probably than the average bear. And like for my bone density scan, the nurse practitioner was the one doing my appointment. And she was like looking at my chart and she was like, does CDH1 mean anything to you? And I was like, oh, yes. Yeah. I was like, gather you round. Let me
Woo, hello.
explain to you. And I spent an hour and a half not only educating her on CDH1, but also how it affected me, why I had the surgeries I had, and kind
Mm.
of like life. She was fantastic. She listened to everything. She wrote everything down so that I never have to do it again when I'm in that office. Uh, but there is like the temptation to have like advocacy fatigue, right? Like that
Yeah.
you're exhausted by having to constantly explain yourself.
Yeah.
And if I could push back and if I could offer a different perspective to other patients, is we get to. There are a lot of families who wish that their loved one was around to explain it to doctors.
Yeah.
We get to. And if we look at it as like, I'm still here. I get to explain this. I am when I woke up from surgery, Rachel walked in and I did not believe her at the time because I was like, oh, you're just saying that to make me feel good. But she was like, you're superwoman. Like you're doing it. And I just say that to all other gastrectomy patients. Like you are superhuman. Like you're doing what everyone else is doing with a stomach, but you're doing it at a deficit. And I think that it makes us stronger. And so maybe we can all just change our perspective and just be grateful. Like you get to live. That's the prize. You get to live.
Yeah, and I think everything that you're saying is on point. And I think, well, first of all, I can't imagine obviously what it's like for you all to have to educate your doctors or nurse practitioners or whatever. I can't imagine. However, I do understand from other rare patient groups that it's common
Mm-hmm.
because you guys learn a lot about it out of necessity,
Mm-hmm.
right? Because it's about survival for you and your families. And so you are a very, very well-informed group of patients. Whereas, I don't know, you could think of some other medical issue or whatever, I don't know, maybe high blood pressure or something. I'd go in and talk to my doctor. I don't really know much about high blood pressure, dude. Just tell me what to do and whatever. You guys are different. And so you're right, it's a double-edged sword. But like I just made a comment earlier about Karen Chelkin Schreiber,
Mm-hmm.
and is that her advocacy has really helped change the face of the care of CDH1 patients, at least in the United States, if not around the world.
Mhm.
Excuse me, I feel like I'm going to sneeze. So in some ways, your ability to advocate is actually a strength in terms of pushing the field forward, such that for people like me, it helps because I want to study this. It's hard to study it. Advocates help raise awareness and money to then allow us to do the research. Rare disease research is often encumbered by not enough funding. And in fact, the Department of Defense grant that I just applied for is aimed at rare diseases. The truth of the matter is there are a lot of rare diseases out there, right? So we're all kind of scraping and whatever. And then the last part about the real world thing is, let me tell you, you guys got a taste of reality when I left. So did I. So did I, man. I'm telling you. Yeah, I remember one day I was seeing somebody in clinic, and I said to one of my team members here, I was like, okay, let's get her scheduled for surgery. She needs an operation, and they were like, slow down. We got to get the insurance approval, and only if we get the approval from our insurance company can we do it. And that was a bit of a slap in the face to me, because like a wake-up call, because at NIH, right, if I said, okay, you want your stomach out, we've talked about it, all that stuff, we're going to do it.
Yep.
And here it's a challenge, because that's the real world, and that's the unfortunate aspect, I think, of our health system, which is there are a lot of people that need help, and there's an insurance company standing between us that's telling us, hey, Davis, you ordered that MRI. We don't think you need it, so we're going to deny it, and you're just going to have to figure it out. And that's been hard for me to learn how to deal with, and I think that makes it difficult on all of us, I think.
Well, and it's hard to explain to insurance companies because I do not care. I even got pushback on my mastectomy. Like,
Really?
yes. And thankfully, my breast surgeon, the girl who does the insurance in her office, she was like, don't you worry. She was like, I will get this.
Nice.
But I ended up having to submit like all of my genetic stuff, but they
Yeah.
denied it the first time. And I was like, look, I don't want to do this. Like
Yeah.
you're kind of
Yeah.
convincing me not to.
Yeah.
But
Yeah.
I mean, it is a battle that I don't wish upon anybody. But
Yeah.
here we are. Here we are.
Yeah.
We get to.
Yeah. Yeah.
Um, okay, let's talk about one more thing, and then I think we'll have to save some of these things for another time, because I have already we took up so much time even getting here.
That's okay. I can stay on a little extra if you want to.
Okay. Drinking water. People look at me like I have 3 heads when I say that drinking water is a challenge after gastrectomy. So I know that there probably hasn't been a lot of research on like the mechanics of it, but can you, in your doctory wisdom, just kind of give like an idea of what's happening?
Yeah, I'll be honest with you. I think you need a little bit of a degree in physics to understand it. But the way I understand it, and the way that Rachel and I, Lopez and I have talked about it, is that water by itself, right, has a certain surface tension, right? It's that force that I guess the water molecules, exert, such that like if you filled a tiny tube with water, right, that water wouldn't just be flat, it would have like a little bit of a curve or shape to it, right? And so when water by itself is going down that tiny tube of the esophagus, it exerts some level of force, or whatever, because of the molecules of the water molecules. And it seems just like certain like soaps can change the surface tension of water, right? It's how bubbles are created and stuff like that. Is that when you guys drink something like, water with lemon or water with some Crystal Light or whatever that stuff is, it changes the composition of the liquid and changes the surface tension such that it goes down differently. And I think everybody kind of intuitively knows this, right? Because we drink things that all have kind of a different quality to them, right? Whether, whatever it is. So our understanding is that, water, when it goes down in you guys, it's causing some, or exerting some force or effect on your esophagus that your esophagus perceives as uncomfortable. And probably part of that perception difference is related to the vagus nerve and the fact that we almost have no choice but to cut the vagus nerve. And I know people talk about preserving the posterior or the right vagus nerve when they do a total gastrectomy. I think it's probably possible. I think most people probably wouldn't do it because, there's no proof. But I think there's some evidence that, the nerves that the vagus nerve that actually starts in the brain and goes all the way down into your gut, it's not just a one-way street of signals. It sends signals down and signals come back up, and we're cutting that. And so we're messing all that up. And I think that's probably one of the reasons why you guys get these weird sensations in your esophagus. So I don't know if that's doctorly explanations, but it helps me understand it a little bit.
And what's wild, I mean, with so many things after surgery, it affects some people, it doesn't affect
Yeah,
others.
yeah,
For me, drinking water is more challenging than eating.
yeah,
So
yeah,
I love food and have not had a problem. Like I still get hungry. I don't know if it's just like cravings or whatever, but I am always down to eat. And but like I used to just love water and would drink like
yeah.
60 ounces as soon as I woke up. And now I don't touch water until at least lunchtime. And
Really?
yeah, I will get super nauseous if I try to drink it beforehand. So,
But what if you cut it with something does that help?
so I have tried cutting it with like drops of lemon, drops of
Yeah.
orange juice. It causes dumping. Like
Oh my
it for
gosh.
whatever reason. So what I can do in the morning, I like to say good morning to my intestines. Uh, and I like slowly wake them up with
Yeah.
bone broth, and
Okay.
and then I will drink like a protein shake. So I'm
Okay.
getting fluids, but it's
Okay.
just
Okay.
not water.
Gotcha. Gotcha.
Um,
Okay. Because I was getting worried that you're going to be dry as a bone.
oh, I'm dehydrated all the time, like just perpetually
Yeah.
dehydrated.
Yeah.
Um, and that's like one of my uh, I try to make it a game. I remember Rachel used to tell me like if you can't try to think of it as like you're doing it for your skin because my vanity is so strong. Like like do it for your skin, do it for your hair, like it affects everything. Um and so that helps. Also like drinking out of a straw, like
Yeah. Yeah.
we all have to like come up with these like different little tricks, but
Yeah.
um you know
So
it
two things, by the way, that strike me, right? Because I've been taking care of a lot of you guys for a long time. You guys are all so different, right? And what works, like you said, what works for one person may not work for the other person.
Mhm,
That's striking to me,
mhm.
right? Because I used to joke with you guys, I think, at NIH, which was, and I don't joke anymore, by the way, was I do the operation exactly the same on all you guys. Like I do it the same way. And yet you guys all have different experiences. So that's number one. And number two is this goes back to how you or how I try to prepare people for gastrectomy. And I say, man, I could try to tell you about a lot of stuff, but am I going to sit there and wax poetic for 20 minutes about drinking water after your gastrectomy? No, it's not even one of the top questions 20 questions that people would come with, right?
Right. And I think that it's I kind of there's a hierarchy of water in my
Yeah.
brain. Like there's like you have like smooth waters and then you have like the rough waters.
Yeah,
And some people look at me like, huh? Because some seahorses don't have like they can just drink straight out of the tap, and I'm like, well, good for
yeah,
you, good for the
yeah,
environment. I can't
yeah,
give me my
yeah,
essentia, you know.
yeah,
And also with this is, and maybe this is mechanical, but when I am doing like my long runs, I just go into it knowing that if I'm going to have to take like in some water, I have to come to a complete stop, like
uh,
take a sip and let it go down. And I think only other seahorses can identify with this, but like I can tell you exactly where the water is, like in my
yeah,
body. I can tell you
yeah,
exactly. And I know like once it's kind of reached like heart level, I'm like, okay, now I can go again. Because
yeah,
if I try to go before that, it will come
yeah,
back up. Like
yeah, yeah,
and then, and then it looks like I'm just working really hard and I'm out of shape.
yeah,
And
yeah.
again, the
But it's,
vanity.
but again, yeah, well, vanity, but it's so funny because would see you guys come into clinic and everybody would come in with the thing that worked for them, whether it was coconut water or
Yep.
smart water or, whatever. Yeah.
Yeah.
So,
And everyone tries to like give suggestions, and I'm like, I've tried that. I promise. Like,
yeah, yeah,
but I'll go get, especially because our summers get so hot here, and I just, if I'm about to go on a trip or if I'm coming home from
yeah,
a trip or whatever, I'll go get an IV and just get
yeah,
saline.
yeah,
And
yeah.
uh, oh, it feels so good. It's so nice. It's the ultimate level of self care. Um,
Okay. Okay. You
but
heard it here first.
you heard it here first. Go get an IV. Um, but not drinking water creates other issues, right?
Hmm. Oh, yeah.
Um, a quick one, dental care, right? Like I have seen
Ah,
such an increase in, and like having to explain to my hygienist, I'm like, I brush my teeth 3 times a day. Like I floss, I use mouthwash, and yet my plaque buildup from pre-surgery to post-surgery, and I kind of think, because I'm not drinking a lot of water, I don't wash my mouth out a lot, so I feel like there's
yeah.
more plaque.
I think again, this goes back to like, there's got to be lots of things involved. So the first
Right.
one is you guys have heard this a lot, I'm sure, not just from Rachel, but other dietitians. When you don't have a stomach, you have to chew your food really well. And so good dentition is really, really important, just even going into gastrectomy. And I remember I took care of some people where they had to go get dental work before we did their gastrectomy. So that's number one. Number two, don't forget bone density and dental health probably go together a little bit, right? And so I think overall having calcium levels that are normal, vitamin D, all that stuff is really important also for your dentition. Um, there are some unanswered questions. And so one of the studies that we're going to try to complete here that we started at NIH was, understanding how the microbiome of the gut changes, but it
Mhm.
starts in the mouth, right? Because you have an oral microbiome, right? There are bacteria that live in your mouth, right?
Mhm.
Hopefully the bacteria that live in our mouth are not as pathogenic as, let's say, like in a cat's mouth or, or a dog's mouth, but right? But the bacteria start there, and then there are bacteria that make it into the stomach, and different bacteria that can live in the stomach, and
Mhm.
versus those that live in the mouth. So anyway, so I think that may be part of it too. Actually, is how your microbiome changes, in the course of having a gastrectomy and living your life. But I think the water thing is probably very accurate too, right? Because when you drink, you're washing stuff around and in theory kind of helping out.
Right. That's a very interesting. Okay, so there's a big conversation about pre and probiotics. Should we take them? Should we not take them?
Yeah.
Because, and this is probably one of the biggest topics post surgery. And let me just preface this with I love that I'm talking about this on the internet, but constipation is probably one of like the most frequent or not so
Infrequent.
infrequent,
Yeah.
yes, issues in life after stomach removal. And I think there's this big misconception that after you have your stomach taken out, you're going to eat and then like eliminate immediately after you've eaten. It's just going to go
Yeah,
straight
exactly.
through you. And I'm
Yep,
like,
yeah.
oh my gosh, I wish that that was the case sometimes, you
Yeah.
know?
Yeah.
Like, um, and if you're watching this and you have a functioning GI system, congratulations, and be so grateful for it.
Yeah.
But what are your thoughts on pre and probiotics? And can you kind of just talk through what's happening in the body, like to cause constipation after
Yeah.
surgery?
So I'll touch on the pre-probiotic thing first. My take on some things, and there are other maybe physicians that would disagree with me, but if it's not going to hurt or if it doesn't hurt you, I mean, like honestly, I mean, and a lot of prebiotic, probiotic stuff is kind of like, based on this idea of like yogurt and cheeses that have a lot of, whatever bacterial cultures in them. So that's number one. But the number one cause of constipation is dehydration. And I think for you guys, as we were just talking about the water part of it, it would then kind of make sense that if you guys are struggling a little bit with water going down even, then a lot of people are just struggling to stay hydrated. I think the other part of it is, and I was telling somebody this the other day, I think it was one of our residents that I was just trying to kind of, teach. And I said, if you think about it, if I go out and I work outside in the yard for, 3, 4 hours and I work up a sweat and whatever, and I come in the house and I fill up an 8-ounce glass of water, I can chug that thing and yeah, I can replace a lot of the fluid that I just lost. You
Mm-hmm.
guys can't do that, or you guys can't do that very easily. And so it's not that you guys are out there sweating, to the oldies all the time, but you guys have to stay hydrated,
Mm-hmm.
and you have to make it more of a focus than, let's say, other people. But I'll tell you, even for me, I've had a couple kidney stones in my life, which maybe that's TMI, but one of the causes of kidney stones is also, not drinking enough. And so I have to make a concerted effort, and of course I don't have it today, but usually I have a bottle of water or a thing sitting next to me at my desk because I have to remind myself I have to drink, I have to stay hydrated.
Mm-hmm.
Because for you guys, lots of side effects, but constipation is a huge one. And oh, by the way, I think because of some of the mechanical changes, the way that your small intestine and colon are related to each other after the reconstruction for the
Mm-hmm.
total gastrectomy, that I think there's a mechanical component to getting constipated and then all the stool in your colon kind of pushing on your intestine. Because a lot of people will say, man, when I get constipated, my bile reflux gets worse.
Yep.
And one day I can draw a picture maybe of why that is. But when your
Wait.
colon is when your colon is full of stool, it's
Mm-hmm.
pretty impressive. And I wish I could take you guys into the operating room and have you lift up a piece of the intestine or the colon or the large intestine that has poop in it, and it's pretty substantial.
Well, and it's also important because it's like if you're constipated, you can't eat. Like
Yeah,
it's like you're full, like
you're full.
you're tapped
Yeah.
out. Yeah.
Yeah,
So,
yeah. So I
um,
mean, but see, it's all goes together, right? You got to drink, you got to poop, you got to. I mean, it's like this is your life, right? Welcome to your life.
yay. It's like I'm an infant, really. It's like make sure that you're fed, you know.
Eat, drink, poop, sleep.
That's it. That's all I do. Yeah. All right, let me look at our list, see what else. I think we kind of hit on everything
Are you
that
sure?
we were gonna
Were there any
hit
kind of?
today.
Well, I thought there was a controversial topic on there.
Um, maybe I didn't write it
Although
down.
we've been talking for almost an hour.
I know.
People are not going to want people are going to watch this on 1.5x, right?
That's that's fine. That's how I live my life. I just All right. Well, how about this? If we missed anything, send me a message, and we will put together an itinerary for our next conversation. And
Yeah.
hopefully by then we can do it on Instagram. Gotta get up to
You
that.
need 29 more followers,
Go follow me,
buddy.
please, so that we can get on Instagram. But I think I'll do my best to post this also to our now YouTube page as
Oh
well.
yeah. The YouTube thing is great though, because then I want to try to post those on like our website, which hopefully can be also like a place for people to go. But I think, listen, this should be helpful. I like the fact that you get people to send in topics. I think that's so cool. Which, by the way, I don't know how to do it, but things pop up on here. But I saw Angela Maddox said hi. And then I saw Nancy Brown at some point. I actually saw somebody who has no relation to CDH1, who's a friend, pop on. They must have been like, "Why is Jeremy on Facebook?" You know?
He's on Facebook. Yes. Well, we'll do this again. We won't wait. I think our last one was like in April, so we will not
Oh, we
wait.
should do it more
Yes.
frequently. The
Yeah.
people want it. You know that we got to give the people what they want.
All 900 of them, almost 1,000. All
I'm gonna
right.
go
Well, I
find
will post
29
this.
people. I'm gonna go find 29 people right now. Get you to 1,000.
Fantastic. And
Okay.
all right, I will post this. Thank you, Dr. Davis, and we will see you next time.
Awesome. Thank you. See you.
Okay. We need a good sign off,
I
like.
know, and also I don't even know how to turn this damn thing off. Like,
No,
what do I
I'll do
do?
it. I'll do it. Don't worry. All right. Bye.
See you. Bye.